So it's always good to get feedback no matter what it is. If there's something you think that needs to be improved, all of that is welcome. We look forward to making the program something that all the listeners can enjoy, something that is very informative, that you can learn something. And more than anything else, what we really would like is to get some interaction, because we have so many wonderful guests on the program, and sometimes we don't get the level of interaction. We don't have people asking the questions, and maybe you're sitting at home thinking about the questions. You still have a little doubt about something. Pick up the phone, send a WhatsApp message.
And while you're at it, let me give you the number 730-5388. Again, 730-5388. Landline 459-7885. 459-7885, or you can also use 459-7888. All right? And persons do say to me, they're prohibited to use a cell phone at work. So hence the reason
Ah,
why.
okay.
Yeah.
But our listeners at home and those of
Yes.
you who can, please
Yes.
feel free. We welcome all of the interactions, your questions, your comments, everything.
And even on Facebook. Yeah.
Yes, Facebook, the Facebook Live as well. Thank you. We have a very special guest with us this morning. Before I introduce her and allow her to say a bit about herself, I would just like to share a notice that I received this morning. Sometimes when we get towards the end of the show, we may not have the time to do it. So I'll do it now. And if time permits, I will repeat. So this one is coming from the Lafag Wellness Center in Choiseul. They have organized a fun walk on Monday, the 1st of April, which is next week, Monday, Easter Monday. So those of you looking for something, very healthy to do, I'm sure there are a lot of activities happening over the Easter weekend. Those of you looking for something fun, something healthy to do on the weekend on Easter Monday, there's a walk taking place, a fun walk taking place from the Dibrel Gap, which is that gap which is close to Massy Choiseul. For those of you who may not be too familiar with the names of the different communities, everybody is welcome. So that walk takes place from the Dibrel Gap to Sabusha Beach, and I am going to look for the time. I think I missed out on the time. Let me see if I can get the start time here. 7 a.m. So it starts at 7 a.m. That's not too early. It gets bright outside quite early these days. So get your sneakers in gear, get your socks, get your active wear, and join them as they take that walk from Dibrel to Sabusha, which is not a very long walk. There are a couple of challenging areas. If you're familiar with the terrain in Choiseul, there are a couple of challenging hills, but that all of that is good for the heart. Yes. So try to make it out there on Easter Monday. Yesterday was World Tuberculosis Day, Sunday, the 24th of March. And I say that because our topic today is tuberculosis. We have with us Dr. Gajadhar, who is the Senior Medical Officer in the Infectious Diseases Unit in the Ministry of Health and Wellness. She will be talking quite a bit about tuberculosis today, telling us what it is, whether it's preventable, whether it can be treated. I recall my earliest recollection of tuberculosis, and it wasn't the name tuberculosis, it was TB. It was that if you heard somebody coughing a lot, you'd hear an older person say, Uni TB, sorti bomwe. So you have TB, move from around me. So that is my earliest recollection of TB. So Dr. Gajada, I'm sure, will be able to give us a whole lot more information as it relates to that condition. And we look forward to it. I was a child quite a number of years ago, so I'm sure quite a lot has changed in that time. The theme this year was Yes, I can, or it is, yes, I can. Yes, we can end TB. So, Dr. Gajadhar, welcome to Casualty 911. I, I think it's your first time on the program, and it's a pleasure to have you. I hope you can hear us.
Hi, good morning. Can you hear me?
Yes, Dr. Gajadhar, loud and
Okay,
clear.
wonderful.
Thank you.
Wonderful. So, thank you for having me, and thank you to all the listeners out there who are tuned in to hopefully learn some information about TB, things they may not know or things they already know.
Okay, so Dr. Gajada, would you like to share a little bit about yourself before we get into our discussion on TBI? I think I gave your designation within the ministry, but I'm sure there might be something else you'd like to share with the public.
There's not much. As you mentioned, I am the Senior Medical Officer for the Infectious Diseases Unit within the Ministry of Health. And so some of my responsibilities include the programming for sexually transmitted infections, including HIV, and the tuberculosis program.
Okay, wonderful. So let us start off by talking a little bit about what TB is. I think most people use that name TB rather than tuberculosis. So I guess we will be moving in between both of them, whichever is easier. TB is quite easy for me to
Mhm.
say, compared to tuberculosis. So could you share a little bit with us about what exactly is TB? Because as I said, my earliest recollection was just, you coughing a lot. And then if you coughing a lot, then you probably have TB. And if you have TB, you should not be around others. So that was my earliest recollection of TB. So could you tell us what it is, what causes TB? What are some of the symptoms? How is it transmitted?
Okay, so TB, there's a bacteria called Mycobacterium tuberculosis, which is where the name tuberculosis comes from, and from henceforth we'll go with TB because it's shorter and easier to say. So there are different forms of TB. So first off, you can have TB that is in your lungs. So you mentioned coughing and spreading the disease. So think of it somewhat like having a chest infection. We're talking about something like influenza or COVID. It's in your lungs, and what happens is when you cough, the droplets contain the bacteria and you spread TB from the lungs that way. But that's not the only TB we have, because we have TB that is not contagious. So, not everybody who is exposed to infected droplets will actually get pulmonary TB. Some people are able to actually clear it out of their body, whereas with some other persons, it can actually be in your body but asleep. That's the easiest way to describe it. So if it's in your body and it's asleep, it's what we call latent TB, and you cannot spread it. So somebody who has latent TB, they can cough, whatever. They're not gonna spread TB until it becomes activated in the lungs. And then we have another form of TB, what we call extrapulmonary TB. So pulmonary refers to the lungs. So we say pulmonary TB. And anything that's outside of the lungs, we call extrapulmonary TB. So some persons can develop infections in their lymph nodes, where you may get swellings around the neck, under the arms, places where we have lymph nodes. And in that case, again, it's not TB that you can spread by coughing to other persons unless you actually have pulmonary TB at the same time. Yep. So we spoke about pulmonary TB, which is the one we can spread, latent TB, which is TB that is sleeping in your body, and then we have extrapulmonary TB, which can infect things like your lymph nodes, your bones, your bladder, and there are other places as well.
So, Dr. Gajada, how would one get latent TB?
So, somebody who is coughing, you can pick up latent TB by getting infected with the droplets. But Not everybody who is exposed to the droplets will develop pulmonary TB, and not everybody who is exposed to the droplets will develop latent TB. And latent TB, it's sleeping in your body. You're not going to have any symptoms of it. You cannot spread it by coughing. Latent TB and pulmonary TB and extrapulmonary TB can be cured. Okay, so we have what we call drug susceptible TB. So that's TB where the medications we have to treat it can be used to cure TB. And then we have what we call drug resistant TB. There are also medications that can cure drug resistant TB, but those are not, they are outside of the normal medications that we use to treat what we call drug susceptible TB. So if you have latent TB, you can go around coughing, but you will not spread latent TB. If you have TB in your lungs, you go around coughing, you can spread TB through the droplets. And to prevent the spread of TB, much like with COVID, where we wore masks, you can do the same thing, right? So you can wear a mask to prevent the spread of that infection through droplets. When you start treatment for TB, what we actually do is we have equipment, technology called Gene Expert. And if you provide a sample of sputum, that's the phlegm that comes from your lungs, we can use it to test to determine whether you have TB or not. And it can also determine whether you are resistant to one of the drugs that is commonly present resistance to TB. That's called rifampicin. So Gene Experts will diagnose TB, and it will determine whether you are resistant or sensitive to the drug called rifampicin. When we want to monitor TB to determine if you are getting better with the treatment, we also use your sputum samples, but we look for evidence of bacteria in the samples, what we call acid-fast bacilli, the bacteria that cause TB. So at the beginning of TB, when you are first diagnosed, we'd use the sample, one of the samples, sputum samples, to determine how much bacteria is actually in your sample. And once we start treatment, we'll monitor you. So we'll ask you to provide another sample to see how much bacteria is in there. And that will let us know how infectious you are. And when you become not so infectious is when you no longer have the bacteria in your sputum. So that means that when you cough, you're very less likely to spread TB because you no longer have the bacteria in your sputum. But having said that, we have rules as to how long you take treatment for TB. So TB is not like influenza or pneumonia, where sometimes you may need a week or less than that of medication. You actually require 6 months of medication for TB. And that can be a lot for some persons. So we have what we call directly observed therapy, short course, it's called DOTS. And we actually want persons to either come to the wellness center where the nurse or the assigned officer will watch you swallow your medication, or you have the option of what we call video dots. So, a WhatsApp call a video WhatsApp call to actually watch the person swallow the tablets at a specific time. You only take your medication once a day. And depending on the type of medication, it can be a lot of pills. So as a result, we watch you swallow the pills to make sure you are taking it. It's a means of supporting you because we understand that 6 months of medication, that is a long time. Based on the number of pills that you're taking, that can be a lot. So, persons are likely to maybe not want to continue this for the full 6 months. But if you stop during the 6 months, you're going to have to start the treatment from the beginning all over again. So it's not simple like when we treat a pneumonia, but the end goal is to cure TB because TB can be cured.
Okay. All right. So, Doc, I just want to go back a little further. You spoke of the three types of TB. Are the symptoms basically the same for all of them?
Okay, so for pulmonary TB, you're looking at cough for more than 2 weeks. You're looking at night sweats. So when we talk about night sweats, we're talking about when you sweat to the point that you soak the sheets, the pillows. You're genuinely soaked, and we're not talking about night sweats that are related to the weather. Yeah, and this is something that continues on. We're talking about weight loss. We're talking about loss of appetite. We're talking about difficulty breathing. And the weight loss can be pretty significant. We will have persons who say, I've been losing weight over a period of time, a few weeks, because they may have had this cough for a while and they, may have seen someone about it, but TB may not have been thought about, or maybe they may not have seen the doctor about it because they may have been self-medicating, thinking that it would go away. Yep, sometimes you can be coughing up blood as well.
Okay.
But when it comes to latent TB, you have no symptoms. You're not going to have the cough, the fever, nothing like that. No symptoms. And remember what I said, even if you cough, you're not going to spread latent TB. But latent TB can be cured as well. And if you're cured of latent TB, there's less likely of a chance for you to develop pulmonary TB, because the idea is that we would have cured the TB that's sleeping in your body so that it would not activate later to become pulmonary TB. And unfortunately, what happens is that if you have latent TB, if there is something that affects your immune system that causes it to not work as it should be. So your immune system is what protects you from germs, bacteria, viruses that are in the environment. And if your immune system is not that well, for example, if you have an immunodeficiency, for example, if you have diseases like lupus, diabetes, HIV, things that can depress your immune system, and you actually have latent TB in your body, then it becomes more likely for it to activate and become pulmonary TB.
Doc, I'm curious, if there are no symptoms to latent TB, how would one know?
Okay. So we have a test called the Mantoux test. So the Mantoux is a reagent, and in persons who have TB, one of the things we look at is what we call contacts. We look at close contacts. For example, you may not live alone in the household. So let's say we have a lady who has TB. She may be married or have a partner, right? um she may have children in the house, and those are persons you interact with on a daily basis. You go into their rooms, you do different things, you all sit, you all eat and have dinner together, so you all are basically sharing the same airspace, so to speak, right? You remember during COVID when we talked about quarantine, the whole idea of quarantine was not to share the same airspace with persons. You wanted persons masked up, so you're not breathing out germs to the persons, in the area that you are if you are infected. So the same idea obtains. So if you are diagnosed with TB, one of the things we want to look at is the persons you've been in close contact with, even persons you hang out with. Maybe you have a group that you hang out with on, a weekly or maybe every 2-3 days. So that's the same persons that you're sharing airspace with. So what we do is we use this Mantoux reagent. It's a tiny needle. It puts a little amount of it under your skin in the forearm, and then you have to go back to get the area looked at within 48 to 72 hours, right? And depending on what happens at the site where the Mantoux was applied, that will determine whether we think you may have latent TB or not. Yeah. So there are different rules and guidelines based on the person who is being tested with the MAM2. And another group of people we like to recommend getting MAM2 done would be healthcare workers who are likely exposed to persons who may have TB, or if you're treating persons with TB. So that would be an opportunity to determine whether you possibly have latent TB because you have no symptoms, but if this MAM2 test shows up signs that you have latent TB, then you can be treated and have less likely, the possibility of developing TB later. Because once you cure it, the only way you're going to get it again is if you get latent TB again. Yeah?
Thank you, Doc.
You're welcome.
You spoke about testing the phlegm. How would you get that sample from the patient?
So it's usually an early morning sample. And we ask persons, we get up in the morning and you want to cough out phlegm. We don't want saliva. We want phlegm. So we want stuff that's coming from the lungs into the mouth. And there's a difference between the saliva and the phlegm. You don't want you forcing to think, okay, I'm going to produce a sample and all I'm getting is saliva. Sometimes if it's a very dry cough, that opportunity may not be there. But if it's a very wet cough, we'll tell you get up early in the morning. There should be a buildup there. And we'll give you instructions as to probably how to tap the chest to try to see how you can get that phlegm coming up.
Okay. You also talked about the support that is available to patients who are being treated for TB in terms of the dots.
Mm-hmm.
How strong is that support system in relation to if a patient probably has not shown up or at the expected hour, would there immediately be a call to that patient, or are there sometimes lapses of a couple of days?
Okay, so first to explain, before TB treatments, if we're talking about pulmonary TB, because when it comes to latent TB, we don't do dots. Latent TB, there are different regimens of medication. Okay, so different groups of medications that you would take or single dose medication. It depends for latent TB, but you don't have to do dots. And the treatment in some cases can be shorter. Like now we have the availability of a regimen where you take it once a week for 12 weeks. Yeah. With pulmonary TB and extrapulmonary TB, it's a little different. So with pulmonary TB, before we would start off treatment in the hospital for 2 months, and once we are sure that your sputum no longer has a bacteria in it, then you would be discharged home for another 4 months of treatment. So the treatment for the first 2 months is a daily treatment. So you take it daily for 60 days. And then the treatment for the following 4 months would be 3 times a week. So think of it like Monday, Wednesday, Friday, right? Which is a bit easier, but again, this is 4 months of treatment. So the idea, we've actually moved the management of both the intensive phase together with the continuation phase. It's all in the community now, unless there's a particular reason whereby the patients would require hospital admission. So for example, if they're very ill and they're not going to be able to manage at home, for example, if someone, lives on the street and has been diagnosed with TB, we cannot in all good conscience send them out there to be treated for TB because they're going to need their meals. Likely they would need to gain weight. And this is not going to happen if you don't have a place to live, right? So very likely if this person has absolutely no place to live, they would require admission in order for them to be treated. So back to your question about dots. So if the person, for example, is in the intensive phase and is on daily treatment, let's say you're doing video dots, you're calling, you're not getting them. Um, you call again the next day, you're still not getting them. This needs to be reported to the next manager in line. So if we're talking about a nurse who's doing dots with a client, that will be reported to their supervisor, and likely their supervisor will come back to the medical surveillance officer and to myself. So let's say this person has gone underground and has disappeared and no family member knows where they are. At that point, because TB is a communicable disease and because you require the full treatment to be cured so that it can no longer um, you will no longer be infected, because guess what happens if you don't finish your treatment? The symptoms are going to start up again, the weight loss, the night sweats, the coughing, etc. And you're gonna have to start your treatments all over again. And as a last recourse, through our chief medical officer, we actually get the police involved. But it really is a last recourse. If we're not finding this person, they've gone underground and we don't know where they are, and there's a likelihood for them to spread it to other persons, we actually would need to get the police involved to get them admitted to do their treatment, the duration of their treatment, until their treatment is completed. Um, Unfortunately, under duress.
Okay. Thank you, Dr.
But
Gajadhar.
that is a last recourse. This is not something I like to lead with. I like persons who it's a give and take, and I understand it's a lot of medication to take. But again, there's a reason why we want to treat TB. We don't want it to spread to other persons. We want to contain it, and we would like, eventually it would be great if we no longer had TB on our shores.
Absolutely. So, Dr. Gajada, speaking of having to bring people in under duress, have you ever experienced that situation?
Unfortunately, yes,
Oh,
it has happened. Yeah.
okay. And what is our current situation in St. Lucia as it relates to TB? How many, can you share with us the number of people currently being treated?
What I can tell you is the WHO measures TB incidence by the number of cases per 100,000 population. So we remain under 10 cases per 100,000 persons, under 8 cases per 100,000 persons. So I can tell you in 2022, we had 2 cases. In 2023, we had 4 cases. I wouldn't go into where we are right now.
Okay.
Because of so few numbers, I just like to. It's not that I'm not sharing information. Because we have such low numbers, I just like to say this is, in terms of the low burden incidents, this is where we are. And I think they may have been figures, at least the 2023 figures that I would have stated in my statement. But we remain a low burden incidence country. We would like to eliminate TB, as in 0 cases, but we also have to remember that we live in a global society these days, and there are countries out there that do have a high burden of TB. And remember, we do get persons who come in, because we do have schools in St. Lucia, where we get students from other countries. So we have to remember that TB is something that can come into St. Lucia, even if we are lucky enough to eliminate it completely.
Okay.
All right, we have some persons with some questions. Somebody's asking, is it compulsory to take TB shot from birth?
So the BCG vaccine is available. There are some recommendations for some persons. Some children who are born, they may not be able to take it because of immunity issues, but the BCG vaccine will not protect you for life. Actually, what the BCG vaccine does it will protect children from getting tuberculous meningitis, right? A type of meningitis caused by tuberculosis. And it offers some other level of protection against TB, but BCG vaccine will not protect you for life, but it is a good form of protection against tuberculous meningitis in children.
Of course, I hope that answers the question. Here's another. Do we exercise that same measure with other diseases, which is just as serious involved in the police?
Okay, so let's step back into time about 2 or 3 years with COVID. If you remember when COVID started, initially with the quarantine procedures, there would have been a need to invoke the police if persons would have tried to escape quarantine, and we know those things changed over time. Unfortunately, with the nature of pulmonary TB, if we have persons who disappear on us, who do not take their medication, under the Public Health Act, we are allowed to do so. I to this moment I cannot think of anything else under the Public Health Act that would allow us to do so. I could be wrong, but from my knowledge of TB, I do know for TB, I honestly cannot speak for anything else except the remembrance of COVID at this point. And then again, I don't know what is to come, if there will be any diseases out there that may cause a recourse like that, but I want the public to understand it really is a last recourse. It's not a first recourse, and it's definitely not something I lead with when I'm speaking to clients, because I don't want clients to think that, oh, it's just going to call the police and do that. I genuinely don't want that. I want persons to understand that we understand it's a difficult course to take for 6 months. We go through what we need to do. We try to do what we need to do. Only as a last recourse will we do that. Yeah.
All right.
Okay. Very good questions coming from our listeners, and we appreciate your responses to those questions, Dr. Gajadhar. I think we had our misconception section coming up, and I think you've answered quite a few of them, but I will go through some so that maybe we can get some further explanation as it relates to some of the things that people have heard about TB, and to delve into whether they are true, partly true, completely false, and so on. One of them is that TB is easily spread through kissing and sharing personal items like cups and cutlery.
Okay, so I'll go back to how TB is spread. We're talking about a droplet infection. We're talking about coughing. The only way I could see it spread that way is if there are bacteria in the saliva, but that's not where we normally go with that. It's all about coughing. So the idea is that your home being treated for TB, there are other persons who live in the house with you, so you have your mask on. If you're in your room, a well-ventilated room, and persons are coming to you, we recommend that those persons put their mask when they come in. And it's all about how infectious you are. So do you remember when I said we can measure the amount of bacteria that is in your sputum? So the idea is that when we monitor you, we're hoping that if the treatment is working as it should, after 2 months of treatment, there should be no bacteria in your sputum. For us to say that your treatment has been completed on the path to being cured, we hope by the end of the 5th month of treatment, there's absolutely no bacteria in your sputum. So I'll go back to being spread by droplet infection. Like everything else, you take your measures. You're gonna be kissing someone. You're not gonna be kissing them with a mask. You're gonna be in the same. You're gonna be in the same space with them. So yes, you're gonna be sharing breath, etc. So you're more likely to get TB from the droplets. when a person is has bacteria in their sputum and can come out through their lungs. Yeah.
Okay, thank you, Dr. Gajada. And there's another one that is very closely related, and I suspect the answer may be pretty much the same. If somebody who is infected, and this one happens very often, we see people spit in public, and it may be a little gross. It grosses out quite a few people. It may be a bit unhygienic. I mean, just to be spitting out in public, but some one of the things that comes up is that if somebody who is infected with TB spits in public, he or she is putting others at risk of becoming infected with TB.
Well, that would depend. If you have sputum in the saliva and if somebody is passing by and they're getting droplets from there.
Okay.
Yes, but in terms of dried saliva, I don't expect you to get TB from dried saliva.
Okay, wonderful. The treatment of TB, is the treatment of TB safe? The treatment used for TB safe? Can it cause death?
So, TB medications, they all have side effects. Persons are dosed according to their weight. Um, we are not going to provide treatment for persons that we think is unsafe. So this we're looking at treatments that have been around for many years, okay? And the TB treatments was an evolution because they may have started off maybe with a single drug and we now use 4 different drugs to treat TB. Happily, those drugs do come in combination pills now, so that will reduce the amount of medications that you take. You can get side effects again with the monitoring that is done, because one of the things TB can affect would be your liver enzymes. So one of the things we do would be baseline tests to see where your liver is functioning, and then we should repeat tests at some point during the period of treatment to see if there are any changes. Plus, we, monitor symptoms. If persons are coming with specific issues, they would have to be investigated to see if the medication is affecting them. So I'm not saying the medication is not going to have side effects. Everything has side effects, but it's for us to see where the patient is at the baseline, what is happening, because I think it would be too much for me to go into all the side effects of medications. Okay, so something harmless, rifampicin can cause your body fluids to become orange. So your tears, your saliva, your sweat, even
Oh.
your feces can become orange, but it's actually harmless. So I always tell clinicians, please tell the client this before so they don't just get upset
Exactly.
when they see this happening, because you're going to be on rifampicin for 6 months. Yep. So that's going to be there for 6 months. Isoniazid can affect your nerves. So to protect persons from that, we put them on vitamin B6. So for the duration of time you're on isoniazid, you're going to be on vitamin B6. Isoniazid and rifampicin you're taking for the duration of the 6 months, right? So everything has side effects, but I'm not going to say that TB medications will kill you. However, I will say that if you are diagnosed late with TB and you start treatment late, there's a chance that you may die before you finish treatment. And that's solely because of how far gone you may already be with the TB infection. Yeah.
Okay. So, Doc, in your experience working with TB and TB patients, do the side effects disappear after the treatment is completed?
Rifampicin for sure, that will go away. If we're noticing an issue with the what we call the peripheral neuropathy, the effect on the nerves, then we need to determine if we need to increase the dose of the vitamin B6. Yeah. Um, In terms of the other two medications, I don't know that we've had any really big issues come up. Um, but if something comes up, we have to look at it on a case by case basis and manage whatever side effects come up. So, for example, let's say someone, remember I mentioned affecting the liver enzymes. So, let's say someone is on the 4 months of treatment and they have an issue with isoniazid. It's affecting their liver enzymes, it's causing them to be sick, it's causing them to vomit. It actually causes what we call an isoniazid induced hepatitis. We may need to stop the medications, give the person some time to recover, or stop the isoniazid cold and then maybe replace it with another medication. There's something else called levofloxacin. So it depends on how badly they may be affected. And the same goes with if somebody is on treatment for latent TB. I've experienced that where a person develops isoniazid induced hepatitis. We actually stop their medication, let their liver recover, and then started them on a different medication to manage the latent TB. So we look at the case, we look at the symptoms, and we determine the best way forward for the clients.
Okay. Thank you, Dr. Gajadhar. We have a few questions coming from our listeners. One is that the person is making reference to HIV and saying that there are many people spreading HIV to others and those people need to be arrested. It's a comment, and those persons need to be arrested and nothing is done about it. So, would you like to comment on the comment?
I would say all of us need to take personal responsibility. One of the things I suggest is if you're starting off with a new sexual partner, whether it be long term or short term, you always are prepared with your condoms. That's number one. Number two, if you're in a situation where you think you have a partner who is HIV positive, we do have treatments out there, something we call pre exposure prophylaxis, which is something you can be on, which will allow you to have unprotected sex with an HIV positive person. However, it will not protect you from other sexually transmitted infections. And HIV is not the only sexually transmitted infection out there. We have syphilis, we have gonorrhea, we have chlamydia. I go back to the personal responsibility in the sense that you may say persons unknowingly spreading HIV out there. Person may not know that they're infected. But it's up to you as a person who is having sex with an unknown entity, an unknown partner, to ensure that you protect yourself from that partner that you're having sex with, because it's not only HIV. And I understand why the allusion is to HIV, because HIV cannot be cured, but we do have medication to treat HIV. We do have medication to ensure that a person with virus in them can eventually become undetectable so as not to spread that virus. But again, I will go back, there has to be some degree of personal responsibility.
I think we lost the audio a bit. No?
How much did you lose?
Okay. All right. I've been reassured that we haven't.
Okay.
Okay. So thank you, Dr. Gajada. We have one more question. Can a fetus have TB? So I'm guessing maybe the person is thinking of transmission from either the mother or from outside. Can a fetus have TB?
So if mommy has TB, mommy is pregnant and mommy has TB, mommy can be safely treated to ensure no spread of TB. That's an interesting question. I actually have to think about that one. I know in terms of HIV, to prevent mother to child transmission, we do have medication that would prevent that. So if mommy is treated for TB, hopefully there should be less likelihood of baby acquiring TB. Um, um, we can have because mommy would be on medication. Let's say mommy has baby and mommy is breastfeeding, mommy would be on medication as well. We do have medication to protect the baby, because there would be going back to what we discussed earlier about the isoniazid and having to be on the vitamin B6. So if mommy is on medication, then baby, we talk about after baby is born, and if mommy is still on medication, then baby would have to be on medication as well. But I don't recall of hearing any cases of mother to child transmission of TB. Actually, I would have to look that one up. I'm not sure about that one.
Very interesting question. I had not thought
Yeah.
about it myself.
Yeah.
So thank you very much for that question. We appreciate all of them. And as Doc said, she may have to do a little more research, but that's all part of the interaction and we welcome that. Okay. So Doc, I have a question in terms of smoking. How does smoking affect a TB patient, if at all?
I guess it would depend on how damaged the lungs are. Because smoking affects the little sacs that collect the air in your lungs. So you smoking, there's destruction of a certain number of sacs. I don't know off the top of my head, how many per year, depending on the number of cigarettes you smoke. But there would be some degree of lung damage there. Depends. And I think a chest x-ray would determine, what extent of damage might be due to TB, etc. But if you're already short of breath with TB, I would not recommend, you know, smoking during treatment. I wouldn't recommend smoking after treatment, but my recommendation would be to stop smoking, because that would have inflicted some damage on the lungs already, and you don't know if that would have partially predisposed you to developing TB because of the lung damage that was already there.
Thank you, Dr. Gajada. So we've had quite a long discussion. So right now, I will invite you to share any last thoughts as it relates to TB. Anything you think that we missed, anything you think that you need to reiterate, you need to repeat so that our listeners can leave with some key messages.
So I want persons to think that just because you hear someone has TB, I mean, there should be no stigma attached to TB. TB has been around for many years. For whatever reason, like I said, not everybody will develop pulmonary TB. Some persons will develop extrapulmonary TB. Persons could be walking around with latent TB and not know. But there's no reason to shun anybody, because they say, hey, you know what, I've been coughing for a while, etc. At that point, you'd have to think to yourself, hey, how long have I been around this person? Have I been in very close contact with them? And is there a possibility I could have TB? And there's nothing wrong in saying, hey, you know what, this close friend of mine, I found out that they have TB. Is there any way I can be tested to see if I have TB? So, think of it like, okay, I found this out. All right, how can I support them? And what do I need to do for myself to see if, there's a possibility I have TB? And if I'm diagnosed with latent TB, I can get treated for latent TB to reduce the likelihood of me getting TB later in life, pulmonary TB later in life. So I just want to emphasize that there should not be any stigma attached to TB. I mean, gosh, do you remember when COVID started? Remember how it was like, oh my gosh, this person have COVID, I have to stay away from them. Now it's like, wow, okay, COVID is kind of like the flu. It's like, okay, you may have COVID, you may have influenza. If you get tested, you find out what you have. But the stigma that was there at the beginning is no longer there. And there should not be any stigma for TB. There should not be stigma for any disease, as a matter of fact. There shouldn't be.
I'm very happy you mentioned that, Dr. Gajada, because the sentiment among some people is that if somebody has been diagnosed with TB, that person should really just be isolated and away from everybody else.
So, I'm diagnosed with TB, right? So I have to look at where I live. Can I stay home for my treatment? Do I have a well ventilated room? Am I separate from other persons? Do I sleep on my own? Right? So that's number one. I have all of those things. Okay, so does that mean that I'm stuck in my house all day? No. Do I have space to walk around? Yes, if I can walk around, as long as I'm not, for the time that I still have the bacteria in my sputum, I'm not interacting with persons without my mask on, I can go out, I can take my walk. I'm not gonna walk up to somebody, take my mask and start to cough in their face. You understand what I'm saying? It's like you should try to keep your life as normal as possible, but again, we know if you're working during that infected period, we don't expect you to be able to be at work. You'd be on sick leave for that period of time. But I mean, we don't expect that persons will come to your house and then they're gonna come and hang out in your room. No, no, that cannot happen. Right? But much the same as when persons were treated at hospital, they were allowed visitors. People come to see them. Obviously, there was distance and masking, and there were rules in place. But you don't just say, "Oh my gosh, this person has TB. I don't want to be around them or nothing." No, that's not the way, because you never know. Remember, you could be the one with TB. So
Right.
think about how you treat people because guess what? You're going to be on the receiving end at some point someday. You never know.
Yeah. Okay. Thank you, Dr. Gajadhar. You put it so well, and I hope that our listeners have really taken that in. Is there anything else you'd like to share before we um, close off the program this morning?
I can't think of anything else, but I'd like to say thank you for having me. I appreciate the opportunity to talk about TB. Thank you for the listeners for enduring. I hope I wasn't too technical with you. I hope I explained it in such a way that you could understand. And I appreciate the questions that came, and especially that question about the baby. I really need to look that one up. That one has put my thinking cap on my head. Thanks.
Okay. Thank you so much, Dr. Gajada. We really appreciate having you on the program today. It was very informative. I think you did an excellent job of explaining everything related to TB, the types of TB, the transmission, the treatment, the stigma, and so on. We really, really appreciate it. And I would also like to thank our listeners for joining us, for tuning in. And I am especially grateful for those who shared questions. Let me give a shout out to Sheldon Lionel and Lucian. I hope I got it right. For asking those questions, because it really, those questions from the public really helps to make the discussion a little bit more dynamic. There are questions, as you said, Dr. Gajada, the one related to the fetus. I had not thought about it, but here is this listener asking a very interesting question. So we really appreciate it, and we encourage our listeners to continue to ask the questions, to make the comments, and to interact with us on Casualty 911 every Monday from 10 to 11. So, Dr. Gajada, thank
Every
you very
Monday
much. And
from
before
10
we
to
end,
11.
and before we end, I just want to remind our listeners of the fun walk. Shout out to Miss Wilson, Louise. I don't know why I'm saying Miss Wilson. Erlen again. Erlen calls her Miss Wilson. So shout out to Louisa. Louisa, I know you probably tuned in and listening. We appreciate it. And for those of you going on that fun walk on Monday, the 1st of April at 7 from Dibrel to Sabusha, make sure you walk close to Miss Wilson. You will be entertained. Okay? All right. Thank you so much, everyone. And we have come to the end of our program. Bye.
Casualty 911, 10
Bye.
to 11 a.m. with the consultant.